Yeah, once again, my name is Joe Panza. I am an assistant professor of OBGYN at the University of Rochester, Division of Urogynecology and Reconstructive Pelvic Surgery. Um, and so I'm going to be talking more about the um, vaginal uterine side of prolapse here. I didn't get a whole lot into things like risk factors and the sort of setup for the case because you've already heard a lot of that. So I sort of try to keep it as simple as possible. And I also do have a video of my portion of the case at the end here. And so, without knowing exactly who's in the audience here, some of this is pretty simple, but just wanted to kind of give a quick overview. So what is prolapse? Just like with the rectum, prolapse is the descent of one or more of the vaginal walls and or uterus or cervix or the apex of the vagina, depending on what surgeries the patient has had in the past. So if they don't have a uterus or cervix, then it's going to be the apex. We divide things into three different compartments here. So in the left picture, basically what you're looking at is very, well-supported pelvic organs, side view of the pelvis. And so I usually show this image to patients and I say, there's the area under the bladder, which we call the anterior vaginal wall. And typically when that prolapses down, we call that the old school term cystocele. Try not to use the terms cystocele, rectocele, enterocele, et cetera anymore, because technically you don't really know what's behind the prolapse. So we try to stick with anterior vaginal wall, apical, which would be your uterus or cervix, and then where the vaginal cuff if they had a hysterectomy, and then the posterior wall here, obviously where the rectum is. In the second picture over in the middle there, what you can see is prolapse of the uterus. And so that's obviously coming down to the point where it's outside the vagina. Clearly uncomfortable for the patient, bulge pressure, discomfort type symptoms. You can see how it compresses the base of the bladder, which is a very sensitive portion of the bladder, leading to things like overactive bladder symptoms, which is urgency, frequency, nighttime voiding, inability to empty the bladder because you have urine stuck in there. A lot of patients with recurrent urinary tract infections. The urethra also gets kinked here, which can lead to low flow voiding, irritated voiding symptoms. And then the last picture on the far right, you can see post-hysterectomy vaginal wall prolapse, which is the top of the vagina coming down, and again, similar symptoms associated with that. In terms of how we measure things, again, this is a little bit higher order, especially if you're not a urogynecologist, but we use what's called the POPQ, or the pelvic organ prolapse quantitative exam. And basically, this is an objective quantification measuring the most distal portion of the prolapse during maximal exertion. A couple different reasons why we have this. One is it's objective, meaning we use actual numbers to measure this. And in the office, I use a Q-tip that has centimeter marks on it, and I literally mark all of these points that you can see in that smaller image in relation basically to the hymen. It also is very good for research purposes and studying long-term outcomes and things like that. And that's really why it was invented in the first place. And then inter-observer variability is quite good on that one. So basically, to keep it relatively simple, everything is measured in relation to the hymen. The hymen is 0 here, so at the vaginal opening. I don't know if you can see my pointer or not, but I'm pointing at stuff. At the opening where it says GH there, that's genital hiatus. And so everything inside the vagina is going to be negative, and everything beyond the hymen outside is going to be positive. And so we measure all of these different points that you see here along the anterior vaginal wall. That's the AA and BA, the cuff, the vaginal cuff, or the cervix. If the patient has a uterus, that's point C. And then along the posterior wall is AP and BP. And then the size of the opening of the vagina, GH, and the PB is perineal body. And, in relation to the combined surgeries, some of the important points here, especially, are going to be the posterior vaginal wall, where you're often going to see a very large posterior vaginal wall prolapse. Most of these patients from either chronic constipation, other pelvic floor issues, and traumatic deliveries with or without instrumentation are going to have very short attenuated perineal bodies as well, which leads to a wider genital hiatus, which is the point between the urethral opening and the posterior fourchette here of the vagina. And the wider the genital hiatus, especially at the end of surgery, the higher the risk of a recurrence of the prolapse or recurrent symptomatic prolapse. In terms of its epidemiology, it's a pretty common thing. So newer studies showing up to 19% lifetime risk for at least one surgery by the age of 80. And that's, 300 up to 400,000 procedures a year in the US. High reoperation rate as well. So up to a third of women are going to need a repeat surgery. Obviously, we wouldn't be giving this lecture if it didn't have a large coexistence with other pelvic floor disorders. And, from my end of things, that tends to be urinary problems, but also obviously fecal incontinence, rectal prolapse, et cetera, all these things that we're talking about, 20 to 30% at least. And in terms of symptoms, I think one thing that's really important that I want to highlight is that prolapse can be present, and I didn't put it on this slide, but the number of women that have some form of prolapse on exam can be as high as like 60 to 70% in women like over the age of 60. And so a lot of times in my practice, I will get referrals for women that have prolapse on exam, either from general gynecology or from a PCP, or sometimes even from colorectal, but they don't have any symptoms of prolapse. The common symptoms being bulge in the vagina, pressure in the vagina, discomfort, problems with intercourse, back pain, difficulty emptying the bladder, urgency, frequency of urination, all those things you see there, constipation and splunting, which is pushing inside the vagina or around the rectum to empty. And if they don't have any of those symptoms, but they have some objective measure of prolapse, nothing needs to be done about it, even if they're going to have a surgery for coexisting defecatory problems. So I think that's something important to keep in mind. And, even with someone who's seasoned and experienced like Jenny, she still sends me patients to be like, just want to make sure there's nothing going on here. There's nothing that we need to treat or anything that we need to treat before sort of I do my isolated repair, which I think is perfectly reasonable. But, these things don't need to be treated. And just because one other pelvic floor defect is being fixed does not mean necessarily that even if they have a small degree of vaginal prolapse, that it's going to get worse with time. In fact, there's been multiple studies in our field that have sort of followed women for years at a time and shown that like up to 60, 70% of prolapse sort of reaches a maximum point and stops. So it's not something that's just going to get worse indefinitely. Before we jump into some of the surgical stuff, just wanted to talk about sort of the levels of support of the vagina. Level 1 being most apical support, so at the top of the vagina. Level 2 being along the length of the vagina, and level 3 is the distal portion of the vagina along the perineal body. This was developed by someone called Delancey out of Michigan, sort of one of the pioneers in our field. And basically, the main thing that I want to point out here is on the left image, you can see this uterosacral cardinal ligament, which connects basically from the cervix up to the sacrum. They call it a ligament. It's not truly a ligament. It's just a condensation of connective tissue there. But that's one thing that's your main support structure. And we can use that for reconstruction. But if it's highly attenuated and pulled, it's not going to do a whole lot for you, which is why we tend to utilize the sacrum as opposed to that ligament in certain patients. This is showing you in the pelvis view here. So you've got the fallopian tube here. This is pelvic sidewall coming over. Here's the uterus. And then you can see uterosacral ligaments. These are quite robust, so these might be good for repair. This is probably a patient that doesn't have a whole heck of a lot of prolapse, but basically you can put stitches through here, and I'm going to show that a little bit later, and attach it to the top of the vagina, as opposed to doing a mesh repair. So we kind of compare those two apical support procedures. So factors to consider, some of this we were kind of talking about, but things are patient goals, activity levels. So the more active somebody is, then the more sort of robust repair you probably want them to have. In terms of sexually active, there's a couple of other types of procedures, which I'm going to show you in a second, just for to sort of round out the talk. There's reconstructive procedures, which is basically what we're talking about. But there's also obliterative procedures, and we have done these. Me and my partners have done these at the same time as repairs that Dr. Speranza has done. These would be done through the vagina, but they basically are repairs to close the vagina. And these can be done also at the same time if you were going to take a perineal approach to a rectal prolapse or something like that. We often do these obliterative procedures at the same time. Have they had any previous repairs? Have they had mesh before? Have they had a mesh complication? Are they at risk for mesh complication based on their age, medical comorbidities, smoking, diabetes, immunocompromised, etc.? Do they have a high BMI? That's obviously going to affect their ability to hang out in, this 30 degrees of Trendelenburg for 4 hours that we like. what's their surgical history? So is their abdomen a mess? Do they want a hysterectomy or not? Have they had a hysterectomy or not? Do they want mesh or not? And then, what else is going on in the abdomen? So this is just an example of a closure procedure for those not familiar. There's two types. One is called a Lafort, which is patient basically with the uterus. So we call it a partial colpocliasis, which just literally means like obliterating the vaginal space. Obviously, very large prolapse here. This is sort of what's happening in the middle. So you can see that basically an incision was made along this vaginal epithelium, and that was dissected away from the underlying connective tissue, which was then put together to form basically a roadblock with stitches. You can see Foley catheter up here. So this is the main vaginal tissue that's been retracted to the side that will all get trimmed off and then closed up, which is what you see on the far right here. There are other vaginal approaches, again, just for completeness sake here. The other vaginal approaches are reconstructive approaches, and they would be to attach the top of the vagina to the uterosacral ligament, which I was showing you before, or something called the sacrospinous ligament, which runs from the ischial spine up to the sacrum. And you can see this vaginal vault here put onto that with stitches that's done through the vagina, and that can be done with or without a hysterectomy. And the problem with these procedures is that some very large, well-done randomized control trials show that the success rate for these procedures is not that great. So, as I, again, explained to my patients in the office, this is basically a hernia, but instead of coming through your abdominal wall, it's going through the vagina, basically. And just like hernia repairs that use mesh, the reason that exists is because native tissue repairs using your own tissue have a relatively high failure rate. And so, these are sort of more traditional procedures, and we still do them a lot, and they're great for certain people, but there's a fairly high failure rate, which is why the mesh is in existence and works pretty good. So that kind of leads us into what we commonly do together, which is going to be apical approaches from inside the abdomen using either native tissue or mesh. So you can do the uterosacral ligament suspension from above laparoscopically, and then we also do a sacrocolpopexy, or what some people would call a sacrocervicopexy, attaching the mesh around the cervix and vagina. And so again, this is the example of the graft. The graft that we use is a Y-shaped graft. I have that in here somewhere, maybe on a subsequent slide, attaching around the anterior and posterior vagina, dissecting the bladder away, the rectum away, attaching that with stitches and pulling it up to the anterior longitudinal ligament. Another just kind of slide on the pore placement here, which and some of the instruments that we use. Dr. Speranza kind of already told you that. Camera position is very important. One thing that she talked about is you want to be 15 to 17 centimeters away from target anatomy. One thing that's really important is we usually line everything up kind of right at the umbilicus. You can't put the camera too high and you can't put the camera too low, because if you do those things, it's very hard to see over the sacral promontory where you really want to put the stitches, more kind of at S1, S2. And so that's something we try to feel out before the case. I physically will feel with my hands and try to see if I can feel the patient's sacral promontory, so I have an idea of where to put the camera, so that I'm not having to finagle that intraoperatively. Again, this is just showing you that uterosacral ligament, which can be done from above. So basically, once a hysterectomy is done and you have an open vaginal cuff, you can put stitches through here, and you basically suspend that by shortening this ligament and pulling things up. And that can also be done vaginally, which is what you see here. So here you have an open vaginal cuff in the image on the left labeled A, and they're grasping that with a clamp, and you're basically putting stitches through that and then through the cuff and tying it down. So what you see in C are the two sides holding up the top. And I often will do this in patients that have a concomitant rectal prolapse repair, if they don't want mesh. So if, like, Dr. Speranza is going to do a biologic and I'm going to do a native tissue repair because the patient doesn't want mesh, or they're a really bad mesh candidate, or they have something else going on. I mean, she's done sigmoidectomies, and I've done this repair in a woman who had prolapse recently. This is basically showing you sort of how we attach the mesh, and I'm going to show the video in a second. So this is the Y mesh. So this is what's called the tail of the mesh here, and it's going to go up to the sacrum. That is one piece of mesh. You can see this piece with the line on it, and this is the product that I typically use now. This is called Upsilon, made by Boston Scientific. This is what we call a type 1 polypropylene macroporous monofilament mesh, and these have been, compared to older meshes, very good ingrowth into the tissue. They have these large pore sizes greater than 75 microns, so they allow for macrophages to get in there and clear bacteria, which prevents them from getting infected, all of these things that are going to decrease our risk of mesh complications. But the mesh complications are pretty much the same rate that you heard from Dr. Speranza. Again, some very, very large, well-done studies in our field. 2 to 3% risk of overall complications, the same for having to go back and do any type of surgery to remove either partial or complete mesh excisions. But I mean, I think that's, in your average patient, it's pretty good considering the success rate is very high. So again, some very large studies in our field, 78 to 100% success rate long-term. Some of the newer studies showing 90% plus, it depends what you define success rate. The ones that are lower here in the 70 to 80% range are studies that have like a composite failure rate, where if you met any definition of failure, whether it was objective, subjective, retreatment, then they would count you as a failure. So it's a little bit tougher as opposed to the actual rates of retreatment, which tends to be less than 10% with this procedure. Actual rates of subjective failure less than 10%. And the interesting thing is that there's a low complication rates overall, not just with mesh, but the rates remain low. So there's a few studies that have looked at rectopexy alone, sacrocolpopexy alone, and then combined cases, and the rate of complications were all the same, interestingly, including major complications. Just to show some anatomy, basically, we identify the sacral promontory by seeing this bump, if you're lucky enough to have a patient where you can see it. Obviously, the main things that we identify on the left side is going to be the colon. On the right side is going to be the ureter, which is in here. You've got your internal vessels, your external vessels. And this patient, they still have their tubes and ovaries. So their ovarian vessels are coming across here. Let's bring the picture on that slide. This is just showing you some of the other anatomy. So the sacrum's over here, and then going from right to left, certainly on the right side as we go down and as we're dissecting away. In my case, I open up the peritoneum, whether, Dr. Speranza's there doing her thing or not. I would open that peritoneum up from the sacrum all the way to the posterior vagina, which gives me something to retroperitonealize the mesh with at the end of the case. But there's a lot of stuff on the right that you can get in trouble with. Mainly it's going to be the ureter, and then there's some nerves over there if you get too far down. And then your internal iliac and stuff like that. At the sacrum, the main thing is going to be the middle sacral artery and vessel, and these are pretty easily identifiable, and we often do sacrifice these just so that we can put nice stitches in here and don't have to worry about bleeding. But there's all kinds of, this thing doesn't look as pretty as this in real life. It branches all over the place, so you really got to be careful. And then the other thing, which can be a major issue, is the left common vein, which is, depressed, obviously, in real life, and you can't really see this at all. And so I'm always telling the fellows, like, they tend to want to make a really big space over the sacrum, and they're always dissecting up. And I'm always like, there's no reason we need to be doing that. Like, stop dissecting that way, because that's a right, you can run right into some of these. But you basically just have to be careful. You take it one layer at a time. And once you find that nice white layer, the anterior longitudinal ligament, that's where you're going to put your stitches in. In terms of the anatomy of the vagina, so right here is the vagina, which is white. Above that, obviously, is the bladder. You can see the tip of the Foley there. And the idea here is you open up the peritoneum above the vagina, you dissect that back, you find the nice fibroelastic connective tissue of the anterior vagina, and you basically dissect down close to the trigone. This is going to be like really easy in some people and really, really tough in others. Just like with that posterior dissection Dr. Speranza was showing, you can have a lot of sort of thickened peritoneum scarring, especially if the patient's already had a repair here done before. It can be really stuck. And then same thing on the posterior side. So what you see here is I like to use something called a Breisky retractor, which is just kind of a flat blade. It's a vaginal retractor, but it's like a flat blade with a handle. And so it's easy to lift up the vagina and nice to dissect off of. You could also use a malleable. That's something that I've used, and also EEA sizer, vaginal. Any of those will do. And then this is just going to show a quick video about sort of the whole dissection here. So what you can see here is we're just opening up. This is a straight stick video. I don't do straight stick anymore. I do this all robotically, but I used to do straight stick. So you guys seeing that okay? Yeah, good. So this is just opening up the sacrum. So again, you can see tubing over here. Yours is going to be over here. Just taking it a layer at a time, opening up this peritoneum. You can see almost a little bit of that white coming through. Is a nice thin patient, obviously, so it's, makes it a lot easier. Lifting up the peritoneum, just kind of exactly what Dr. Speranza was showing. And then, her dissection would continue down here and around the rectum. For now, I'm not going to do that. So again, here you can see, this looks really nice. You can see the, just kind of taking that last layer off. And you want to really clear that sacrum off, because if you don't, you can kind of pull in some of this extra peritoneal tissue and connective tissue overlying the sacrum, and that can pull some of this vasculature. You can see how many little vessels there are in here. It's not a pain until you get into some of those vessels, and then you get bleeding, and then you can't see anything, and then it becomes a whole disaster. So you want to really achieve good hemostasis. So here we're looking at the anterior vagina. So we just lift up the peritoneum, we dissect that back, kind of just make it nice and wide. That's another thing. We want to make sure we have enough room for the mesh here. Nothing too special about this. Basically, you just want to make sure that there's enough of the peritoneum dissected away, also that you can retroperitonealize the mesh at the end of the case. So then at this point, you can see we've reached down basically to the vaginal wall here. Sometimes this is really thin, especially in postmenopausal patients that have had a hysterectomy. I tend to give people vaginal estrogen leading up to surgery to try to thicken that up. Sometimes I'll use like micro stitches to plicate this tissue to thicken it up, because you don't want to get a mesh exposure. So once this area is pretty much all dissected down, we have room for our mesh placement. We'll leave that alone for a second. We'll go posterior. We flip the retractor upside down to give us a little more retraction that way. And this is fairly easy in terms of how this is coming down. We almost just pulled this down, which I normally wouldn't use a technique like this. Use a little bit more sharp dissection and cautery here, but once that's pretty well developed, I will bring in a ruler and measure that space. So just like Dr. Speranza said, I tend to cut the mesh on the outside of the patient, and I taper it to fit sort of the curve of the vagina. One of the things that can decrease your complications from mesh is going to be the burden of mesh. So the less you can put in there that does the job, the better. This is just showing, again, opening up that space to the right of the colon. Again, your ureter's over here, so you got to be careful. And I just connect that to the posterior space. This is putting the mesh on anteriorly. So again, we've got that cleared space. The mesh lies nice and flat. This is a different mesh than I used to use. It's the same type of mesh, but it's different. In this case, using an extracorporeal, not a tying, just because it's a straight stick case. And that's how I used to do it. So we tack that down. I use Gore-Tex sutures sometimes. These will be partial thickness bites. So if I'm using Gore-Tex, I'm not going through and through the vagina. I don't use a lot of Gore-Tex on the vagina anymore. I tend to use Vicryl stitches now on the vagina. If the patient has a cervix, I will use Gore-Tex through the cervix just to decrease the risk of mesh erosion. Once you pop a few stitches in there, you go posteriorly. If I'm using Vicryl, I tend to do more stitches. I'll do like 3 rows of 3 instead of just the 4 stitches. And then same thing on the back side. You're just attaching this with stitches. Same thing, partial thickness bites, so you don't want to go through the vagina. You could have your assistant check to make sure you didn't go through the vagina there. Tie those down. Great. Then once that's done, you attach it to the sacrum. So what I typically do is I'll approximate the mesh to the sacrum with the instruments, and then I'll do a vaginal exam just to make sure it's not too much tension, but it's reducing the prolapse. So here we've gone through the mesh. We're going to go through the sacrum here, or through the anterior longitudinal ligament, I should say, and then we'll go back through the mesh. And then we'll do that again You don't have to do this necessarily robotically. You can go right through the ligament and then put the two ends of the mesh through, or sorry, the two ends of the suture through the mesh and then tie it down. But it's a little bit easier when you're doing the extracorporeal, not trying to pull this through. The other thing about this is the ligament isn't that thick, right? It's like 3 millimeters thick. So you don't need big bites through it. If you're getting a bite of ligament, you really need very small bites. This needle is fairly big that comes with the Gore-Tex. Typically when I do this with Dr. Speranza, she likes to use the Ethambond suture, and it has, because it has this nice little needle, so you can take these like what look like huge bites, but they're actually very small bites. And so it makes us feel like we really got a nice bite of tissue there. And so you put the other one through, then that's kind of your finished product. And then that gets retroperitonealized, which basically you will see we just kind of take the two ends that we dissected and sort of pull it over the top. And that decreases risk of mesh complications. Some people don't retroperitonealize. There's been a few studies that have shown no difference in complications, so you don't necessarily have to. But I like to leave things how I found them. So kind of typical symptoms of prolapse. So a little bit of difficulty emptying the bladder. She actually did have some urgency and frequency, but no UTIs, no blood in the urine. She didn't leak any urine at all. She had, what's interesting about this patient is a couple of things. One is she's obviously very young. So typically like a 32-year-old, you're not going to see this in. The thing about this patient is she never had any children before. And likely, I think she probably had some underlying connective tissue disorder that, and you'll see this a lot with people, that, it's not necessarily like an Ehlers-Danlos or a Marfan's or like, any of these things that we know of, but there's got to be some underlying genetic problem. I think she told me actually after the surgery that like almost every single person in her family has had like 3 or 4 hernia surgeries. If I remember correctly, I think she told me that after the case, which makes sense. So when I initially saw her, she really didn't have a whole heck of a lot of prolapse. By the time we decided to do the surgery, and we took a very long time kind of setting her up because she's young and we knew, it was going to be a lot to sort of go through all of this for her. And also she ended up getting a hysterectomy. And so I really wanted to give her a lot of time to think about that, which she was totally fine with, and it all ended up fine. But from the time I initially saw her to the time we ended up doing surgery was about 18 months, I think. And she went basically from having kind of like borderline stage 1, stage 2 prolapse to having her uterus almost like halfway outside of her body. So that was kind of an interesting thing. Father scores on the testing, and then we do typically do urodynamic testing for these higher grade prolapses, which is basically like anal manometry, but for the bladder. That's it.